Good afternoon, ladies and gentlemen. For this research, we analyzed the heart rate and heart rate variability generated in the sinus node that represents the regulation of the autonomic nervous system. In my first video, I show how to analyze heart rate variability using a 24-hour Holter ECG. Now, I will explain how to perform autonomic diagnostic with the active standing test using the Biozyne device. In the future, I think there will be new technologies to analyze the autonomic nervous system using smartwatches. For our research, we use time domain and frequency analyzers. However, we try to return to the simple heart rate measurement in the 24-hour Holter ECG and the active standing test, while mostly represents the success of a therapeutic intervention. There are important individual differences in vagus activity, represented by the parameter RMSSD in this slide. Again, we can recognize the steep increase of vagus activity by autonomic imprinting within the first 1,000 days of life. There's a further steep increase during puberty and a steep decrease between 40 and 15 years of life, and a further slow decrease of heart rate variability until the death. We can find patients with obesity in this red-colored group with low RMSSD values, as well as those children with attention deficit disorder or short stature. Some infants are born with heart defect or premature born who have very low vagus activity at the beginning of the life. Others, like athletes or anorexia nervosa patients, have higher vagus activities than normal. And all this have an impact on prognosis by cardiovascular disease. We will now present our data in the active standing test. We have modified this test to a 5-minute lying period and a 5-minute standing period while analyzing the online ECG with a Biozyne device. We have measured this test in more than 500 children partially treated with omega-3 fatty acid, methylphenidate, atomoxetine, guanfacine, and beta blockers. We will now present our data of the active standing test. For practical reasons, we have modified this test with a 5-minute period lying and a further 5-minute period while standing. We control the treatment success of omega-3 fatty acids, methylphenidate, atomoxetine, guanfacine, and beta blockers. We have published our data with more than 500 children in this publication with my daughter Julia. Our data clearly indicate the methods that may be used for diagnostic of autonomic dysfunction in children. To diagnose an inappropriate sinus tachycardia, you need a Holter ECG that clearly show the elevated heart rates that are not detectable in the active standing test. On the other side, you cannot diagnose the postural orthostatic stress syndrome in the Holter ECG. You need the heart rate increase of more than 35 beats per minute in the active standing test while continuously monitor the heart rate. These are significant data as well in the postural orthostatic stress syndrome as in the inappropriate sinus tachycardia, but we found no significant difference in children with vagovasal syncopes. However, we found significant constitutional features in children with autonomic dysfunction. Most of all, there are high and slim patients who developed postural orthostatic stress syndrome, and the inappropriate sinus tachycardia was found in those children who have a higher body mass index. There is a predominance of females in the vagovasal group. The fast Fourier analyzers in the active standing cast show clear data in compared to healthy infants. These are the high frequency, low frequency, and very low frequency power in healthy children in the lying and standing position. Those children with a postural orthostatic tachycardia show a collapse of the heart rate variability during standing, and those with inappropriate sinus tachycardia show a collapse of heart rate variability during standing as well during lying. And in some patients, there's a changing between post-orthostatic tachycardia in one measurement and inappropriate sinus tachycardia in the next measurement. We know control or therapeutic approaches in children with autonomic dysfunction. There are some treatments like lifestyle advice, drinking more, taking more sodium, alternating showers, sports, and increasing body mass index. And the slim children, we nearly advise omega-3 fatty acids in all children with autonomic dysfunction. There are some patients who receive low-dose beta blocker, most of all propranolol 10-10-0 or ivabradine 5-5-0. Some children with a high symptomatic load need midodrine to control orthostatics. There's only one patient with pyridostigmine and another who receives sodium infusions. I now demonstrate some cases. This is a boy after mononucleosis who developed fatigue and show clear postural orthostatic tachycardia syndrome at the beginning, and after 5 months omega-3 fatty acid, the POTS is gone. It's a long time, and it is unclear what happens if the boy didn't receive. In the next slide, there's the active standing test of a girl who received ivabradine, of course, chronic Lyme disease. She didn't go to school for more than 3 months, and that's the reason why we use that therapy that clearly improve the heart rate increase in the active standing test, and the dry D picture of vagus activities, it's a fast Fourier analysis, show this flat collapse of heart rate variability in standing at the beginning of this therapy, and the development of vagus activity in the standing position after ivabradine therapy. In summary, most of our therapeutic approach clearly significantly decrease the heart rate increase during the active standing test. There's a comparable decrease of beta blockers and ivabradine. There's only a small decrease in midodrine, and a further significant decrease after omega-3 fatty supplementation or refeeding in children with anorexia nervosa. Guanfacine didn't change the heart rate increase while standing, but the stop of methylphenidate clearly decreased the heart rate increase during active standing test. There's no significant effect on heart rate increase with only lifestyle advisors, but we found in one patient a clear heart rate decrease who received Astonin. If we differentiate the impact of this therapy on the heart rate at baseline and standing, there is a decrease of heart rate with beta blockers more while standing compared to the baseline heart rate. The same effects are shown in children who receive ivabradine. In the other drugs, there is an increase of heart rate at the lying position, but a decrease of heart rate in the standing position with, in summary, a decrease of heart rate decrease. There is a similar decrease of heart rate while lying and standing with guanfacine, and there is an increase of heart rate at baseline in the patient who received Astonin. Looking to the effect on vagus activity, only the beta blocker improved vagus activity while lying and standing. The ivabradine therapy reduced the baseline vagus activity as well as midodrine and omega-3 fatty acids. We have to realize that most patients who received omega-3 fatty acids have a high vagus activity at the beginning of the therapy, most of all those with anorexia nervosa. In this video, I have shown how to diagnose a postural orthostatic tachycardia syndrome that is often overlooked by your colleagues. Your patients are so disappointed that most physicians don't know the postural orthostatic stress syndrome, that they have organized themselves in a pressure group called Dysautonomia International. I hope that you will not overlook the patient that need your help. Most of all, in those patients with post-COVID syndrome or long COVID syndrome, you will find many patients with inappropriate sinus tachycardia or postural orthostatic tachycardia syndrome that will improve their quality of life if they receive the drugs shown in this video. Thank you for your attention.